Well, I have been here several times for a variety of reasons, including encouraging the hospitals to commit themselves to graduate education. I'm David Dale, and I was going to comment. My first time here was 49 years ago. I came to the Benton County Medical Society to talk, and I talked about antibiotics and antibiotic stewardship, and new antibiotics at the time. My interest now is in being a general internist, but I've practiced in the field of hematology and to some degree in oncology for a long time. I actually completed my training before those specialties were specialties, so there was a lot of latitude you could do back then. Okay, well, here we go. I'm going to talk about 4 topics in hematology, really at the interface of hematology and oncology. Let's see. So the topics are anemia, when to worry about malignancy, early signs of hematological malignancy, and how do I care for patients with malignancies. First case. This is a case of a 59-year-old salesman from La Paz, Bolivia. I haven't even been to La Paz, but it's at 12,000 feet. And he's a smoker, and he's short of breath. His physical exam shows he has a chest that looks like he has emphysema. And his CBC results are a white count of 10.2, a hematocrit that's elevated at 55, and hemoglobin of 17.3. So what would you do with this man? Since he just recently moved from La Paz, would you say, well, come back in a few weeks and we'll check those values again? Would you advise him to stop smoking before he comes back? Or to go to the laboratory and get an erythropoietin level measured? To get a genetic test because his hemoglobin is high, or a full CBC before you do anything else? Well, first thing to always know is normal values for red cells and other blood cells. In my practice, I actually pay attention to this, and the level of the hemoglobin, I find it's very useful to look at previous data, particularly when somebody has got a high value or a low value, below the normal. But it's actually very valuable to look at it in comparison to their previous values to know what the significance of it is. This table is just the normal values, but always remember that the patient's own values when they were healthy are so much more valuable than the population values. You may recall from somewhere from medical school or previous talks you've heard about the regulation of erythropoiesis. It's actually a very interesting and a very dynamic system with the role of the kidney and the bone marrow and the lungs being connected in this circle of regulation of hemoglobin. And a key discovery about almost 30 years ago was the discovery of erythropoietin as a protein that you could identify, measure, and even administer to people. And it was a real big event around 1990 when we had erythropoietin to administer to patients with anemia. I remember particularly the first patient who ever got erythropoietin was a patient with chronic renal failure on dialysis. And this woman came to the classroom at the university where I was teaching and talked about her life before and after getting erythropoietin. She was young enough to have young children. She talked about all the things she could do with a higher hematocrit value. And I was very impressed. And it was actually a stimulus for me to persist in my research on the hematopoietic growth factors. Anyway, this patient, this man from Bolivia, had polycythemia. But was it primary, that is, the red cell production was unregulated, or secondary to the fact that He was a long-term smoker and lived at high altitude. I've actually been to La Plaza, and there's a lot of people there with polycythemia, and most of them function pretty well. And among them, though, there must be patients who develop polycythemia vera, or the malignant form of red blood cell production. In our patient, as I described this man, he had come shortly from Bolivia, and if his red cell production was being driven by erythropoietin, you could probably measure at that time a high level. If he was in Seattle for just a few days, that erythropoietin level would drop and drop to really zero. And so the problem of measuring erythropoietin in this man is the dynamic changes that might be going on. So whatever value you got, you wouldn't be able to interpret it if it was really driving his erythropoiesis or not. So in my view about clinical medicine, I wouldn't measure it if I didn't know how to interpret it. Maybe you have that view too. It's an interesting part of medicine. So how to make the diagnosis of polycythemia vera in this interface between hematology and cancer. First is knowing normal values, and then knowing the other features of polycythemia vera, which include an elevated white blood cell count, usually, but not necessarily, but an elevated platelet count, which is very important. And the reason for that is that the genetic dysregulation that goes with the mutations that cause this disease affect both platelet formation and red cell formation. So they go hand in hand usually. So an elevated platelet count with an elevated red cell count is the clue usually to the early diagnosis of polycythemia vera. As I said, the EPO level in this case would be hard to interpret. A bone marrow examination would probably be hard to interpret too. It would show lots of red cells, but in the bone marrow, the ratio of red cells to white cells in development is quite variable, and the sample is always small. So I would say not necessarily valuable in the early diagnosis. What was new in this arena a few years ago, actually, but a lot of people still don't know it, is that there is a specific mutation in what's called the JAK2 kinases, one of the genes which drives the proliferation of cells. And it's remarkable that it's one specific mutation in this gene that is associated with polycythemia vera. It's a change, but in just one amino acid that makes that particular kinase in red cells drive unregulated production. So in polycythemia vera, the people with this mutation will have high red cell counts no matter what you do. In terms of what you do about polycythemia vera, if you're the generalist, you like to be early with the diagnosis. The last patient I saw with this was a Seattle bus driver, and I went ahead and measured the mutation in the kinase, and I then referred him to the hematology group for treatment. And they said, "How did you know to do that?" And I said, "Well, everybody ought to know that." Anyway, it's a very interesting disease. It's a malignancy of erythropoiesis, and it's relatively easy to treat in the early phase. The treatment involves first phlebotomy to keep the red cell count down, so it's not causing, if you will, sludging in the vasculature. And then the second is to be aware of the potential for the platelets in polycythemia vera, more than most inflammatory diseases where there's an elevated platelet count. In this disease, patients have high platelet counts and tend to get thrombosis. So treatment is usually aspirin. And other anticoagulants are usually not necessary. And then if the disease progresses, there's a variety of kinase inhibitors which are used now for treatment. And they work pretty well. There's not a curative therapy, but there's a beneficial therapy. So the things to take away about this disease is to know that polycythemia is something that happens to people all over the world. It's certainly important in this case to discourage smoking because there's no real long-term health benefit. And then to be ready to discuss the complications and be sure that when you see a patient, if they have itching or they're not on aspirin, or they tend to be progressing in other facets of the disease, that you need to pay attention and do something. The signs that are going to be available to the generalist will be those of progression of the disease and its comorbidities. Now, my next case is that of a 72-year-old retired teacher coming to your office complaining of fatigue. And as you probably know, fatigue is about the most common symptom we have. In fact, some of you may be fatiguing right now, at least parts of your body, just from sitting. But I apologize. But fatigue is such a common symptom that I always say, tell me more. That is, it's not enough of a symptom to make a diagnosis of anything. But in this patient, the physical exam didn't tell you what it was. His cardiac exam, to your knowledge, seemed to be normal. You order a blood count and a metabolic panel and liver tests, and including then you ordered a sedimentation rate. And the two things on those laboratory values of significance, one was that the hematocrit was down, 32 is low, not very low, but low, and the sedimentation rate was elevated. Not as high as it can be in some diseases. We heard a talk earlier about temporal arteritis, where sedimentation rate is often over 100. But here it was a 60, which is quite high. If the normal upper limit normal is about 20. So what would you do? So you have a little anemia and a SED rate that's elevated. I said you could schedule a return visit and complete the physical examination. You could order a chest x-ray to look for some chest-based malignancy. You might order blood cultures since septicemia causes elevated sedimentation rate, although this patient didn't complain of a fever. Or you could order a protein electrophoresis. And the signal here is that there are just a few diseases associated with elevated sedimentation rate to note. Some are bacterial infections, but the clue there is usually fever plus fatigue. And usually there's a finger or an arrow pointing to what part of the body is infected. You know, the heart of the bowel, the liver, or somewhere. There's another signal. But one of the other causes for an elevated electrophoresis or an abnormal electrophoresis is multiple myeloma. So in this situation, when you see a patient with no physical signs pointing to a particular area, and you have a reduced hematocrit, an elevated sedimentation rate, I've made the diagnosis of myeloma at that stage by doing a protein electrophoresis and seeing what I found. Usually, multiple myeloma, the reduction in the red cell count is with normal cytic, normal chromic anemia. But if you look at this blood smear, you may see red cells that are stuck together. Now, that's a remarkable feature. It goes with increased immunoglobulins and also with an increase in the fibrinogen as a stimulus to liver production of that protein. So those two things both make red cells stick together, but seeing it overtly is a trigger to think about multiple myeloma. But as I indicated on the slide here, when I see a patient with fatigue and anemia, I'm looking for another clue. And I just said a clue like the suggestion of iron deficiency and iron loss through the gut with a GI malignancy or overt bleeding, or splenomegaly and lymphadenopathy to suggest either an infection or a lymphoma, or leukocytosis and fever, as I said, to suggest infection. Anyway, the couplets really help you with the diagnosis. Now, multiple myeloma is a pretty common disease. It presents itself most commonly with pain in the bone, where plasma cells are bursting forth in unregulated growth. It's associated, as I said, with anemia and elevated sedimentation rate and rouleau on red cells. And then the protein electrophoresis, the simple test that we've been doing now for 50 years, usually gives you a strong clue to the diagnosis. The technology in this area has evolved enormously in my years in medicine, but the basic finding of an excessive protein in the blood that is what we see as a spike in the gamma globulin fraction and elevated the total gamma globulin. And then we see this spike, which is regarded as what we call an M spike. Now, the older clinicians in the room will probably remember that in multiple myeloma, you also have leakage through the urinary system of a protein. We used to call it, and still call it, if you remember it, the Bench-Jones protein. But it's protein in the urine that's being produced by this abnormal clone of cells that's small enough to not be reabsorbed by the urinary system. And so it leaks out and you can find it in the urine. And in this situation, you're looking for clues to something that is clonal. And also there's a number of genetic abnormalities that you can find. In terms of other laboratory tests, it's common if the patient has bone pain, or what seems to be bone pain and not joint pain, you tend to want to do a scan or an x-ray of some way to see if there's in fact invasion of the bone by malignant lesions. They are pretty common, although often not seen at early diagnosis. One of the dangerous parts of multiple myeloma is the association of the expansion in the bone marrow with hypercalcemia, mobilizing calcium at a rapid rate and leading to renal failure. And that's a part of this condition that's so important to diagnose early before irreparable damage occurs in the kidneys. This is just a picture. Some people say a picture is worth 1,000 words. And if you see these cells in the bone marrow, you will remember them always. I used to tell them in jargon, they're like protein machines. And what you see in these cells is a big nucleus that is, the chromatin is separated. There's usually a signal that they're proliferating cells. You see this clear zone. If you remember, that's the endoplasmic reticulum. That's the network off of which the proteins are made. And then the protein themselves are all this blue in the cytoplasm. So these cells are like gorged with excessive protein that they produce and then will leak into the blood. So it's a very dramatic picture, and actually the diagnosis is based on seeing in the total cell population you look at under the microscope, more than roughly 10% of these cells. Now, multiple myeloma is a very treatable condition. It's one of the diseases of the blood system which has more evolution of treatment than almost any other. I think it seems like almost every other week there's a new treatment for multiple myeloma, and the trials can't keep up with the new drugs. The old treatment was 2 drugs, melphalan and prednisone. That's where I grew up with, and most general internists could treat people with melphalan and prednisone, very easy oral therapy. But that's passé now. The current treatment involves a set of drugs that I've listed here. Bortezomib and lenalidomide and dexamethasone are sort of the basic drugs that are used. And then, if possible, if the patient is relatively healthy, autologous stem cell transplantation after this aggressive chemotherapy is the usual therapy. If patients are poor prognosis and couldn't stand an autologous transplant, they're usually treated with the same group of drugs, although there's a whole list of secondary drugs that are now used to treat multiple myeloma. Most people with multiple myeloma, though, survive for a number of years. But one of the unique features is that if you try to mobilize the cells of their hematopoietic system after you suppress the malignant plasma cells, and to get enough stem cells for a transplant, it's really hard to do. And a few years ago, I was involved with discovering a drug which will mobilize the stem cells even in people with multiple myeloma, even after treatment. And one of my good friends called one day when this drug was not yet approved and asked me if I could possibly help him to get it. And I did, and he survived at least 5 more years, which was very grateful. Anyway, it's an interesting disease, but most generalists, most of us in the here, and myself included, don't treat the advanced stages of multiple myeloma now. Our job is to make the quick and ready diagnosis. So my emphasis in this condition is to know a little bit about it. It's a chronic disease, and some people have the feature of what we call a globulin of unknown significance, or it's referred to as MUGUS. Sounds pretty bad, doesn't it? But it's a protein being produced by the plasma cells in an increased amount, but it's not yet enough of that protein to cause disease or to recommend treatment. And there's a lot of people who have a clone of cells that produce something, but they don't ever become frankly malignant. And I wrote some problems here, are the patient. I think one of the things that people with this disease do is they worry, and they worry a lot. If they know a little bit, they worry a lot. And they suffer from their bone pain. They worry about renal complications. They have a risk of infections of all sorts. And then they complain of fatigue. And the fatigue is out of proportion, I think, to most other people with illness, probably in part because of their worry, but because also it's a chronic inflammatory disease marked by this increase in sedimentation rate. Now, my third case is a 69-year-old retired football coach who shows up in your office for his annual exam. His only complaint is decreased libido and fatigue. His physical exam is unrevealing, but his CBC attracts your attention. And you can see it here, and you can quickly see the abnormality. White count slightly elevated. Hematocrit is slightly decreased. And they would be compared to normal or compared probably to this man before. And he had a differential count. Now, in my practice of medicine, I find a lot of value in the CBC itself. I'm talking a lot about anemia here, but not a lot about anemia that I know, but focus on anemia, because a decrease in the hematocrit is a signal that somebody is ill, and it's your job to figure out what. And then you look for other clues, and I said, combining two things gives you a clue. So he's got an elevated white blood cell count and a decreased hematocrit or hemoglobin. And the clue comes from the differential of the white count that's slightly elevated, not a whole lot, but his counts you can see there, his polys and segs are normal. He's got a couple of bands, but he has lymphocyte count of 6,000 or 6.0 times 10 to the 9th per liter. Now that's not very high, but it's not normal. The normal level is roughly, upper limit is about 5,000, and everything under the sun suppresses the blood lymphocyte count. So if you have acute infection, if you have endotoxemia, if you have most inflammatory diseases, if you have most autoimmune disease, the lymphocyte count in the blood goes down. It's as if the lymphocytes are out in the lymph nodes and spleen doing something, making antibodies or something. But anyway, the lymphocyte goes down, and there's not much that will raise the lymphocyte count except for CLL. So that's a strong clue to what's wrong with this man. So I've told you the diagnosis for sake of time. It's chronic lymphocytic leukemia. If you see a man like this next week, I'd say the chances are 90+% that that's what he has. But he may just have a little bit of it. And it's an interesting disease because it's chronic. This is a picture of the disease. This is probably like somebody's blood who had more than 6,000 lymphocytes. But the big round cells, lymphocytes are easy to see and detect, but they don't give you a diagnosis. Usually, patients with CLL are older men. They have lymphocyte counts, as I said, above 5,000. The cells are usually classified if you do that with staining or some selective markers. They're B cells. And the patients have a very indolent course. That is, they are sick for a long time, but it doesn't affect much their life expectancy. And so it's always a question of what to do. And one thing to do is do nothing. And I've followed patients with this illness that had a white blood cell count of 100 or 200,000. And they were fine and I was fine. But at some point, something nearly always happens. And the things that happen are infections, worsening anemia, or a variety of autoimmune complications that are very severe. The therapies in this disease have also evolved enormously. We used to treat most patients with a drug, chlorambucil, and it was very effective to reduce the counts. But that's not what's done anymore. There are a whole variety of what we call targeted therapies toward the specific genetic abnormalities of the disease. And so it's usually, for a generalist perspective, a disease for referral and for counseling the patient until there's a specific thing to do. Now, if you look at the details about this disease, there's an enormous amount of information. I have reference lists if you'd like it, but it's an area that's evolving rapidly. There are genetic abnormalities in about 80% of patients. They involve a whole variety of different chromosomes and genes. And the specialists in this area group them into about 5 different groups, whether they relate to prolonged survival, increased proliferation, and different specific genes that affect the number of cells in the circulation. The treatment is usually initially chemotherapy. It's rare that people get transplanted for CLL, although it's a possible therapy. And there are a number of second-line drugs, which are becoming first-line drugs, that are also very effective after initial chemotherapy, so that patients often go through a series of drugs until they usually have either hematological complications or they get fatigue. They get treatment fatigue because they're all the time going to a doctor for something. But it's a disease which remarkably the therapies improved and longevity has substantially increased during my years in medicine. So in a primary physician, your objective is sort of like with most chronic diseases, to guide the patient to get good treatment, to help them in terms of psychological support, and be sure you understand the basic principles for the diagnosis of chronic lymphocytic leukemia. Because if you practice very long, you'll see it. Now, my last case, case 4, is a 38-year-old school teacher who comes to your office for the first time. She has fatigue, fever, some symptoms of a urinary tract infection. The urinary tract infection is probably why she came, but not necessarily related to her diagnosis. you're concerned that she may be anemic because she has fatigue. So you do a urinalysis and order a CBC. And your surprise is her white blood cell count is 1,800 or 1.8 times 10 to the ninth. Her hemoglobin is only 7.5 with hematocrit of 27. So that's more severe anemia than in the first three patients I mentioned where we saw them at presentation. This is a more severe presentation, and she also has thrombocytopenia. The differential count in this patient shows she has reduction in all of her cells, particularly her neutrophils and her lymphocytes. What would you do next? And my little list here is review medications and drug history. Whole variety of drugs might do this, from sulfa drugs on to less common medications. You could go to the laboratory or somehow find a way to look at the blood smear. Is she got big cells, little cells, microcytic cells, cells that are suggesting hemolysis because they're fragmented? And you could look at the white cells to see if you thought the technician was right in the differential. You could order iron and iron studies, iron level and TIBC. That might be helpful with this degree of anemia, but it also might be normal. You're worried, scared, and uncertain, so you refer the patient to a hematologist. And you refer the patient because anytime you see pancytopenia or multiple cell lines, that's time to think about cell production or the bone marrow. And as a generalist, you usually can't see the bone marrow. You have to ask somebody to help you. And if you do a marrow on this patient, here's what you might see. And I've labeled it with a diagnosis of myelodysplastic syndrome. Myelodysplastic just means that the cells are not normal, and all types of cells are not normal. And here in this little tiny picture, we see no mature neutrophils. That's always a clue of badness for me because I've studied this area for a long time. And then you see big cells that are producing hemoglobin, marked by this one with this big blue around it in the sort of in the middle, just above the middle of the slide. And you see some other cells, you don't know quite what they are, but there are too many of them. The marrow usually, if you ever look at bone marrow, is about 50-50, or maybe a little more skewed toward myeloid cells than erythroid cells. And you only see a few lymphocytes. But this marrow is abnormal because that's not the picture. And so a hematologist will label this as myelodysplastic syndrome. And this is a syndrome which I say is usually presents with pancytopenia or anemia, leukopenia, and thrombocytopenia. The patients may have symptoms of an inflammatory disease with fever. The bone marrow shows what I just showed you, and nearly always there's some genetic abnormalities. In fact, there are, from a clinician standpoint, too many. You have just a lot of different mutations usually. If you do selective mutational analysis or do whole genome analysis or exome analysis, all those will usually show you a panoply of abnormalities. And trying to sort them out into what's wrong with the patient is not yet possible. So myelodysplastic syndrome, when you have a patient with this condition, it's really hard to know exactly what to do. If the patient's severely anemic, we might transfuse, that works, but the transfusion response just lasts for a few months. If you have thrombocytopenia, it's the same story. This level, 75, is not a particular problem. But if this patient got septicemia or some severe infection, the platelet count would probably plummet because the abnormal marrow just can't make platelets rapidly enough to keep up with the tendency for platelets to be removed rapidly with serious infection. So it's a threat, but it's not an immediate risk. The treatment for this condition is usually cytotoxic chemotherapy. If patients can tolerate it, they'll have a bone marrow transplant. And I've known some people who've actually been very successfully transplanted with this disease, but it's the only curative therapy. So a relatively healthy person with clearly diagnosed myelodysplastic syndrome will look for a potential allogeneic bone marrow transplant. And that sometimes works, and when it works very well. But otherwise, it's a gradual course, mostly to the patient's demise. Well, that summarizes my talk. Basically, that hematology is a field where we have increasingly precise diagnoses at the clinical level and at the genetic level and at the molecular level. And it's good to get on the train or to know about this information, particularly when you have a patient with one of these conditions. You can learn a lot. And the second point is that the improving prognosis for malignancies in the hematopoietic system is a strong driver in terms of patient care to know what you're doing and to be sure you recognize diseases early and that you consult and refer appropriately. Regardless, my third point is regardless of what the circumstances are, patients with these malignancies need your care and support. Most have family, they have lots of issues that come up at the time often of a sudden malignancy, and they do need you to be their interpreter and care provider regardless of what's happening. And so I would make my final point that each patient like this, each time you see a hematocrit that's a little low or a white blood cell count's a little high, it's a chance to learn something and in that sense, to have professional growth and to do what our conference is about, to keep up with medicine. Thank you very much. Anybody have a question?
Thank you. Family medicine. I see a lot of women, childbearing age, that have low MCVs, and it so often seems that once they get down to about an 82 MCV, they're often low on ferritin. And yet I find that the reference ranges will go down to 80, or you showed one that went down to 78, I think. And I don't know if I've ever seen a woman at 78 that is really not low on ferritin. Could you explain why that is, why the reference ranges seem to be lower than what the actual symptomatology is showing us in practice?
And the symptom you're identifying is fatigue.
Yeah, often fatigue, and they're pale. They get short of breath going up their stairs to their bedroom.
Well, iron deficiency is a somewhat complex topic. I mean, there are a lot of different parts to it, but the diagnosis we usually make is based on red cell number and ferritin. I think the hidden elephant in the room, if you will, is iron as a component of myoglobin and muscles. And years ago, a study was done at the university, not with people, but with mice, where you had a normal hematocrit, but you had iron deficiency. Bleed them and transfuse them, you could get to that state. And they got terribly tired. They couldn't run on a treadmill. So I think in that situation you're describing, supplemental iron is a good idea, even though the ferritin is not, or the transferrin may be high and the ferritin just borderline. I would certainly try for a 3-month course of iron supplementation. I think, and the estimate of blood loss with menses is very not very quantitative. And so I think it's an ample reason to at least see if iron will help. And then the other part is to search for some other inflammatory condition that's contributing. Other comments or questions?
My question is on the low MCV. When do you chase those thalassemia if patients is asymptomatic?
Low MCV.
Yes.
Right. A low MCV is, as was mentioned, classic for iron deficiency. But there are a lot of people with low MCV who are not iron deficient. In one category of people, Mediterranean heritage who may have a trait for thalassemia. People with sickle cell disease often will have a low MCV. And you can get a low MCV with chronic inflammation as well. Not low, but intermediate low, while you'll be worried about, you'll think about iron, but you should also think about inflammation. I always say if you have a low MCV to look at the red cells, because if someone who has red cell fragmentation with any sort of disease affecting the internal vasculature, there's a variety of conditions, but abnormal formation of red cells or broken up red cells will give you the indices of MCV, but the cause is fragmentation. That's the path that I would follow. The part about heritage or how that causes the red cell size to come down in thalassemia and thal trait and so on, I don't actually know. It's a membrane question though. How big is the balloon or the package that causes the abnormality? Not how much hemoglobin you put in it.
I
Yes.
had one other question. In my elderly population, I see more and more with an elevated MCV above 100, 102, 104. Of course,
Yeah.
alcoholics, you can get way up there. What's your best treatment for that?
Well, there's a variety of drugs that can elevate the MCV. The drugs that suppress erythropoiesis even moderately, I guess the drugs that are used to treat arthritis or rheumatoid arthritis can contribute to that. I was thinking immediately of methotrexate is associated with an increased MCV. So if you look at the drug picture, you can try to think of drugs that may be influencing red cell production. We measure B12 and folate kind of like a knee jerk, and so often it's normal or just a little low. And many people are put on B12 with just a little low, but it doesn't do anything. Yeah. But it's always to search for whether they have either folate or B12 deficiency. I think that when I see elderly people like that, I ask them what they eat. And they tell me, you know, what they eat. And then I take that with, as they say, a grain of salt, and don't always think that they've told me the whole story. Because I think many, especially people who live elderly who live alone, have a very limited diet. And I encourage them always to take multivitamins. The chance that it's truly a megaloblastic anemia, though, that's pretty uncommon now that we know as much as we do. And 100 years ago, when pernicious anemia was a common disease, the things we learned in medical school were probably very relevant, but it's awfully hard to find somebody with pernicious anemia anymore. Does everybody know what that is, pernicious anemia? That's an old term for the lack of absorption of vitamin B12. Any other questions? Well, I'll be happy to leave the floor to the next speaker. And to thank you all for coming and supporting this conference. And for Jimmy, who made it really, got it all started. And I remember the day Jimmy asked me about the idea, and I thought it was a great idea to have a conference involving people from this broader community in one place at one time, and to do it when we knew there was a conference in Spokane and one in Seattle. It was perfect to have a conference in the middle. So thank you very much.